there in front of my present friends from the Physician Forum. My duty is to talk about what is the new in oncology. We all know the cancer or malignancy is a big challenge in the community as well as to medical fraternity. The hallmark for cancer always remains that early diagnosis. And for that, we all should be aware, awareness should be of high order. And once we make an early diagnosis, the management and the outcome becomes very, very promising. Now today, we will just take the once we diagnose what are the modalities left for the treatment of cancer. As we all know, medical therapy, that is chemotherapy, radiotherapy, and the surgical intervention. Today, we will be talking about what is new in oncology, what is new in medical oncology in particular. So this has been recently talked about immunochemotherapy, which has been talked a lot about it, when to start and how to start and how long to give it. This has definitely improved the quality of life of the cancer patient and as well as increased the numbers of years of the patient's life. To highlight and to brush up with this latest development, we have Dr. Sajjan Rajpurohit. Dr. Purohit is an MBBS from Moderator Medical College, MD from Moderator Medical College, and DM from Medical Oncology, Rajiv Gandhi Cancer Institute, Research Institute, Delhi. Dr. Sajjan is also ESMO Immuno-Oncology Preceptorship from Geneva, Singapore, and MD Anderson Center, Houston, which is, I think, Makkah of the medical therapy in the world. Dr. Rajan has an experience of principal consultant at Medical Oncology, Max Multi-Specialty Center, Noida, and consultant unit head, Medical Oncology, Rajiv Gandhi Cancer Institute, New Delhi, managing medical Asian Journal of Oncology, at present consultant, Rajiv Gandhi Cancer Institute and Research Center, RGCI, RC, New Delhi. From 2000, Medical Director, Mansaran Hospital, 2007. Dr. Rajan has been awarded a lot of awards, particularly the best oncology in the North India, best oncology in North India, oncologist of the year in next annual meet 2016. Dr. Rajan has got a lot of scientific papers to his credit, national and international. I think he is one of the renowned and eminent oncologists in the town. We'll be honored to hear what he has to say about the new in the medical oncology. Over to Dr. Sajjan to carry us forward this series.
Thank you, sir. Thank you for such kind introduction. And I echo the group's sentiment that today it's been a really sad day and it has been really heartbreaking news for all of us. And I hope, sir, that things become better for us. And thank you again for joining and taking your precious time out today evening to discuss about what is new in cancer. So as the world has been evolving, we have been now facing blockchain and cryptocurrencies in the other domains. We have also seen the growth of immunotherapy, targeted therapies, as well as CAR T-cell therapies in cancer. So, Nitish, if you could just put in the presentation, that would be good to maneuver our discussion. So, I have kept the presentation very simple and it will not be very elaborate. I will help us understand what is happening in the oncology domains in various aspects, and then I will be more happy to have the discussion with you and try to answer if you have particular questions in your mind, sir. So, Nitish, could you, okay, very nice. So, if you could just see here, so in 1950s, so if some of you who would have read this book, Emperor of All Maladies, so that is written by Siddharth Mukherjee, and he is a medical oncologist of Indian origin, right now practicing in US. And this book was actually a very acclaimed book based upon the history of cancer and dating back from Egyptian mummies to the current day. We all will be surprised that in the 1950s we didn't have any treatment for cancer. So when Sidney Farber, he started his research on pediatric cancer, especially leukemia, he could hardly have any drugs. And 1960s we saw the emergence of 5-fluorouracil and methotrexate. And 70s we started having platinum as one of the active agents. 80s saw the rise of anti-tumor antibiotics like anthracyclines come into the picture. Till 2000, we didn't have many drugs. I would say there were only a handful of drugs. In 2001, we had the first targeted therapy because by the time we were actually finishing the Human Genome Project, and because based upon that data, we found that there could be the genetic mutations could be targeted with cancer pills, and that was taken as a landmark. The first cancer pill, which was imatinib, when I was doing my MBBS, that came into existence, and it was a big, I would say, story in the cancer. That was a poster boy for cancer treatment. So over the last 2 decades, if we just see, the kind of 5-year survivals have increased at least 20 to 25%. That means in 1950s, the 5-year survival across cancer would just be dismal 35%. Whereas now it has increased to the tune of around 70 to 75%. That means a huge stride in cancer survival have occurred over the last 2 decades. And that is what I think, even when you have been practicing, many of you have been practicing, and you have been seeing patients in your practice who are diagnosed with cancer. Often than not, you would send them back to their places and you would tell them that don't waste your money on cancer treatment. It is futile and it will not yield anything. And chemotherapy used to be a really bad experience for many patients. And patients would say it is better to die than to undergo chemotherapy. So that is what has changed over the last 10 years. And now I see that most of my patients, I actually treat them in daycare rather than even admitting them. So a sea change has happened. But also along with this, one more thing has been happening very silently. So right now, the whole world has been speaking of corona. People have been speaking of Delta variant, Omicron, this and that. You'll be still surprised that even today in India, almost every year we are having 20 lakh cases of cancer being diagnosed and almost 9 lakh cases having deaths or mortality because of cancer. And that is a very huge number. That shows that cancer has become number 3 cause of death worldwide. And in 2025 and beyond, it will actually become the number 1 cause of death. So a silent pandemic has been actually rising in the background of human prosperity and the behavior and lifestyle changes. And that is one thing which we all need to be aware and understand, that cancer should be diagnosed early if we would like to increase our results and improve survivals. So before I could join, I heard Dr. Mathur and some of my eminent colleagues discussing that if we don't diagnose it early, still many times it is not that very good. But in cancers like breast cancer, cancers of the blood cancers like lymphomas and leukemias, we have a huge stride. So even a stage 4 breast cancer today can on average survive for up to 3 to 4 years, and many of them are able to survive even 10 years in stage 4. So there are many success stories with cancers, but there are certain other cancers like gallbladder cancer, pancreatic cancer, which are still lagging behind, and we are really curious to understand what is making them not work, not our drugs work into certain cancers, whereas other cancers we have made huge strides. Next slide, please. So this I will take you through the landscape. So there have been improvements not only in the early diagnosis, better awareness, but also in the treatment. And this chart shows that across cancers, there have been better treatments which are available and also earlier diagnosis. In fact, you'll be surprised that there are 2-3 cancers, especially the cancers of cervix, which has been a success story, especially in the developed world, where it used to be the number 2 cause of cancer in women, and now it is number 10 in UK and US, where effective cancer vaccination in the form of HPV vaccination done in children has now decreased the trend of cervical cancer. It has ceased to be a public health problem in women in the developed world. Still in India, we are struggling with this cancer, the number 2. Also, cancers which are induced with hepatitis B and C are seeing a downtrend, especially the hepatocellular cancers. And also, there are other cancers which might be related to chronic infections that are also going down. So there are certain cancers which are related to chronic infections are going down. However, one of the important menace has been the tobacco-related cancers. The tobacco-related cancers constitute around 40% of all human cancers. So one carcinogenic element having almost 64 carcinogens is responsible for around 40% of all our cancers. I don't know how to help the government, because as physicians, we have to spread this message that the most vulnerable group which gets this habit is in the high schools as well as in early college areas. And if we could prevent the masses from making this as a part of their lives, we could actually have a drastic change in the cancer incidence, especially the lung cancer and the head and neck cancers. So tobacco is one area which can be hugely impacted by behavioral changes as well as our awareness at the level of physicians as well as oncologists. Next slide, please. Next slide. So this slide shows that the average increase in the expectancy which has been gained across various tumor types. Next slide. Next slide, please. So I will delve with some of advances in medical oncology. So chemotherapy has been almost synonymous with cancer treatment being very painful. People would all often say, hey, that is this some poison? What is this going to do with my body? Is the treatment going to be really dreadful? And in 1980s and 90s, I believe that cancer pain and cancer treatment used to be almost similar, and people would endure chemotherapy in the hope of surviving for some more months. But now, with the better control of chemotherapy drugs, side effects, understanding the chemotherapy drugs, and the new chemotherapy drugs coming up, we have been able to effectively control these side effects. The most important side effect, which used to be number one side effect, which was a deterrent to chemotherapy, was chemotherapy-induced nausea and vomiting. Nausea and vomiting would be so bad that people would actually have so many vomitings in the chemotherapy wards that they could actually die of dehydration. The chemotherapy wards used to be awful. The oncologists would actually pity their patients. They would also feel that what kind of a suffering these drugs are giving these patients, for what meaningful benefit. Apart from this, there were issues of alopecia, mucositis, febrile neutropenia, and sexual dysfunction, and various other side effects which would happen with chemotherapy. How this has changed over the last 10 years. Next slide, please. Next slide, please. Keep scrolling. Yeah. So now we have growth factors which are available, which are able to prevent any major marrow depression with chemotherapy. So nowadays chemotherapy has become much safer because we have very effective growth factor which can maintain the WBC counts of the patient and prevent any neutropenia and thereby prevent serious infection which can be associated with chemotherapy. Please scroll down to next slide. Next slide. Yeah. So we have now very effective drugs against chemotherapy-induced nausea and vomiting. These drugs almost make chemotherapies effectively vomiting-free, and almost 95% patients would have no nausea. So nausea and vomiting, a major symptom, has gone. The WBC, which would sink down, has almost gone out of our practice. And now we are also moving towards alopecia-free chemotherapy. So even in some drugs which cause alopecia, they can be prevented by new technologies like scalp cooling technology, where the person uses the scalp cooling caps during the chemotherapy, which we have at BL Kapoor Hospital, and especially with ladies who would have a strong body image issue once they would have hair loss, can prevent such kind of hair loss with therapies. And this has been routinely used in our practice, and this also prevents alopecia. And so hair loss also is now being prevented. So apart from these three important landmarks, the other side effects are also being prevented with supportive medicines which are much better and chemotherapies which are much safer. Next slide. Now, apart from systemic treatments, we are also now going through regional therapies. So if we feel that there are certain tumors, like tumors of the ovary, tumors of the stomach, sometimes tumors of the appendix and the colon, which would actually not go beyond the abdomen or the peritoneum, we could go for regional therapies like HIPEC. So HIPEC is being routinely used in our practices. What is HIPEC? So HIPEC is hyperthermic intraperitoneal early chemotherapy. So such regional therapies are being given during the surgery. So once a person's tumor is removed, their peritoneum is washed and instilled with chemotherapy during the intraoperative period, and in the post-operative period, patients recover, and then they sometimes don't require any chemotherapy further. So a regional chemotherapy is being preferred in certain tumor types and is one of the regional ways to prevent systemic side effects. Next slide, please. Also, very commonly for liver tumors, we are using transarterial chemoembolization, also known as TACE or transarterial radioembolization. So we are going for regional chemotherapies as well as regional radionuclide dye injections, which will lead to only tumor being hit in the regional area. Because we know that all hepatocellular carcinomas are only selectively supplied by branches of the hepatic artery. So our intervention radiologists, along with the oncologists, do a regional cannulation and give chemotherapy only to the local tumor site. Next slide, please. Next slide, please. So apart from chemotherapies, what has been fascinating is the novel cancer targeted therapy. What is targeted therapy? So we now understand that all tumors happen because of either the upregulation of the proto-oncogenes and becoming oncogenes or loss of tumor suppressor genes. The most common tumor suppressor gene having P53. There are many proto-oncogenes, and if those proto-oncogenes which they produce the proteins and they produce receptors, if they can be blocked by small molecular drugs, like which we prevent, for example, our viral infections or parasitic infections, such small drugs can really have a huge impact on cancer treatment. And if we are able to find these mutations, we can target them. So these are oral pills. Can we just scroll down? Yeah, next slide, please. So now, across many tumor types, we are having drugs which are oral, which can be taken in the pill form once or twice a day. And many tumors, in fact, many of you would be personally knowing patients who are being treated with such drugs. And these are pills which have been taken at home. And many tumor types or many cancers are being treated like diabetes or hypertension. And this is one fascinating area where we feel very happy when our patients are put on oral drugs and they can come on follow-up 3 months to 6 monthly, and we just keep checking their how the tumor is behaving. So many of these drugs are into clinical practice. More than now 50 drugs are into the practice. Next slide, please. Next slide, please. So every year, please keep scrolling. Yes. Every year, almost 7 to 10 drugs are coming into different tumor types in a clinical practice. So every year, accelerator approvals are being given for these drugs. And because of the high throughput screening methods and the new drug discovery systems, there's been a rapid advancement in the new drugs. And that's why, in fact, even in COVID, because of the accumulated knowledge from cancer, the cell biology, we have been able to produce such quickly the vaccines, as well as now we have drugs which act on the COVID virus and make the symptoms much less compared to a person who would not be treated with antiviral drugs. So our knowledge from HIV as well as from cancer has helped us deal COVID pandemic much better compared to any other pandemic in the past. Next slide, please. Also, one more fascinating thing which has been, like sir was talking about, immunotherapy. So what is immunotherapy? So we all know that our body has a response to all foreign agents, whether viruses, bacteria, fungi, in the form of forming antibodies against them. But why does it not kill the tumor cells? So that the answer lies in the fact that they are our own body cells. So it is like ghar ka bheti dhan ka dhai. So how does it affect? We are not able to find that which is a cell which is abnormal. And now we are able to convert our antibodies and make them recognize these tumor cells as foreign. And the principle by which they would be able to not be recognized was known as immune escape or immune editing phenomena. And now we are able to find and make antibodies against these tumor types. The specific antibodies are produced by the body's T cells, and when they go and hit the tumor cells, they are able to kill them directly. So almost in today's world, we have almost 10 to 15 tumor-directed antibodies across various tumor types which are being used commonly. And in very soon future, in next 2 to 3 years, when we again have a meeting, we will also have CAR T cell therapy in India. So CAR T cell therapy has also been a part of primary antigen receptor T cells. They are genetically modified T cells which do not require anything, and they are directly able to go and kill the tumor cells. And that technology is almost been approved in US and is routinely used in large centers in US. It will take some time to come to India. Next slide, please. Next slide. So the future is actually bright with the treatment of cancer, and I am very sure that by 2025 we will have much more effective management of cancer than what we have today. Next slide, please. So this is what I was speaking to you. The CAR T cells, which are the chimeric antigen receptor T cells, they are body's own immune cells, genetically modified to recognize tumor cells and kill them in the body. And they are now known as living drugs. So our own body is trained to kill the cancer. That is really fascinating with the help of gene editing and gene modification. Next slide. Also, in the diagnostics, we are now not dealing with the same tumor in different individuals similarly. So one person's lung cancer is different from other person's lung cancer. And we are able to genetically see what kind of mutations are happening in one person compared to other person. And this is being made possible with the role of next generation sequencing as a part of tumor biology assessment. So now we are moving towards personalized medicine in cancer, and we don't deal all cancer patients as same, even in one particular lung or a liver cancer. So this kind of a management is also becoming a part of our management, and this is being now routinely done in India. Next slide, please. Next slide. Yeah. So also from the genetic pathway, we are now moving towards epigenetic and the tumor microenvironment studies. We understand the tumor biology, the tumor microenvironment, and working on them also. So not only the genetic changes, but also the extra genetic changes are being modified and drugs are being produced against them. A lot of drugs coming up in cancer. Next slide. We are also understanding what causes metastasis. So if we could prevent metastasis, the cancer will become much less dangerous. So when we see benign tumors, we are very happy because we know benign tumor, even if they grow to 10 kg, 20 kg, 15 kg, still they are not going to any other place. So those tumors can be removed, and many of my colleagues put their posters in the newspapers. They say, I removed 20 kgs, but most of these tumors are benign tumors. So a benign tumor is not a problem. A malignant tumor is a problem. So if we are able to prevent metastasis, and these pathways are being hit, and tumor studies are already going on in animal models, and very soon we'll have drugs which are able to prevent metastasis. So these things will make tumor much less harmful to us than any other way. Next slide, please. So this is my last slide, and I hope in the last 15 minutes I was able to just give a gist of what is happening in medical oncology. So this is a gist of what is happening in medical oncology. Side by side, a lot of things have been happening in surgical oncology. So surgical oncology has evolved from going from open large radical surgeries to organ conservation surgeries to now laparoscopic surgeries and now to robotic surgeries. BLK Maths Institution has got a huge robotic surgery program, and we routinely perform almost 100 onco surgeries with robotic assistance every month. So that has been one of our forte in my department, and we are very happy that our patients are able to recover faster and have much safer and much faster removal of their tumors. Also, in radiation oncology, a lot of changes have happened. Now we have proton therapy which has come to India, apart from the normal safely delivered radiation in the form of cyber-9, in the form of IGRT and IMRT. So with this, I will stop here, and I am happy to take any questions you have from the members.
Thank you, Dr. Sajjan Rajpurohit. It was a very nice talk. You've given a really insight of what's happening in the medical oncology or management of the cancer in the newer approach. Definitely, we are enlightened by your talk. It's a very, very nice issue. May I now I will start from Dr. Tulsi out of Stalwart to start the questions from Dr. Sajjan. Over to Dr. Tulsi first. Dr. Tulsi, unmute yourself.
Yeah. So, Dr. Purohit, what a wonderful talk, made such a difficult subject so easy. So, the treatment of cancer has moved from a reactive to a proactive discipline. And the molecular diagnostics like biomarkers and personalized oncology is having a remarkable impact. Not to forget, the CT and the PET and the interventional radiology are already influencing early detection and management. So you talked about early detection, which is so important. So the landscape of cancer care has changed dramatically over the past decade, as you said. Now tell us about, we have oncotic drugs or chemo, then immunotherapy, MABs, checkpoint inhibitors, immunomodulators. I talked about the T-cell therapy as well, which is adoptive cell therapy, and radiotherapy as well. So multiple options available, but choosing a treatment plan often would depend on the type and the stage of the cancer. What do you say, sir?
Sir, I totally agree. I think you have summed up really well, sir. So I agree. So that is, I think we are moving from a mass treatment to a class treatment, and that to a precision-based medicine. We are moving from, like, we would have one size fits all to one size fits one. So that is where we are all moving, sir.
Right. So, do you get any side effects of the CAR T-cell therapy like CRS, which we observed in the COVID?
Sir, with respect to CAR T-cell therapy, yes. Right now, CAR T-cell therapy, we are in second generation of CAR T-cell therapy, sir. And it has got a lot of off-stream, I would say, off-target effects on the body. So when we are activating these CAR T-cells, they end up also having immune-related reactions, like they could have hypophysitis, they could have immune-related lung injury, they could have cytokine release phenomena occurring. So, like we moved from 1G to 2G to 3G to 5G now. So very soon we'll have very precise CAR T-cells being formed, and there are already almost there are 5 big pharma companies, the big 5, working on these kind of therapies, and I am very hopeful that they're working on making the CAR T-cell therapy more effective, more targeted, and having less off-target side effects.
So just a word about the non-Hodgkin's lymphoma, who are not experiencing symptoms may not require treatment and probably just an active surveillance. What do you say?
Sir, so there are certain non-Hodgkin lymphomas like small cell lymphoma, some of them marginal cell lymphoma. So these are the two varieties. They are very low grade sometimes, and when they are stage 0, stage 1, observation is possibility. There are also marginal zone lymphomas which are H. pylori associated. So once you treat H. pylori, they regress.
So those are
and some
mantle cell lymphomas.
Yes, sir.
Yeah.
Marginal zone lymphomas, not mental. Mental is a more aggressive variety. So if I were to say which are the lymphomas, I will say there are 4 lymphomas which are in low grade, which can be observed for some time. One is small cell, other one is follicular lymphoma, third one is a marginal zone lymphoma, and sometimes a splenic marginal zone lymphoma. So these 4 type of NHLs can be observed, because sometimes they might be actually living longer than the person itself. So there we can wait. Rest also we have to treat.
So Dr. Purohit, tell us, immunotherapy, how long? 3 times a week for 12 weeks, how long? 2 years, how long?
Okay, sir. So now immunotherapy again is like cancer, sir. Now like cancer is very broad term. Same way immunotherapy is a class of drugs. Now we almost have 25 different type of immunotherapy drugs available with us, and different tumor types will have different setups. So there are tumor types where if they are given in adjuvant setting, we have to give for around 1 year. There are patients who are metastatic. They might be required to give minimum of 2 years, sir. So the range can be from 1 year to 2 years, sir. Normally in adjuvant we are giving 1 year, and if it is metastatic, the patient is doing well, then we continue till 2 years, and beyond 2 years, there is no additional benefit of giving immunotherapy. Most of the patients we stop.
Right. So my last 2 questions would be, Dr. Purohit, HIV patients, see, they are at higher risk of developing lymphomas, and not only lymphomas, aggressive lymphomas like diffuse large B-cell lymphomas, Burkitt lymphoma are usually seen, and also leading cause of death in HIV patients. The lymphomas cause death. So they are at higher risk of developing even Hodgkin's lymphoma and Kaposi sarcoma, which is a rare form of skin cancer. And if the CD4 count is low, can you give them monoclonal antibodies or immunotherapy?
So, sir, for our HIV positive patients who develop malignancies, our prime aim is that they should at least have a CD4 count of minimum 200. Because below 200 we don't treat them, because it's very difficult to give them chemotherapies also. Immunotherapy can be also safely given if it is targeted immunotherapy. Normally for lymphomas we have anti-CD20, so which acts on B cells, whereas we are looking for T cell, but then we would like the T cells to be at least 200 in count. So CD4 count has to be at least 200. Preferably it is 400, no problem. Beyond 400, no major problem. But if there is still less than 200, we wait for that count to recover. We give them HAART, and then we start it. Yes, sir.
I'm glad you said that. Okay, now small cell lung cancers, Dr. Purohit, we have lost two very eminent physicians amongst us, and it has had a dismal prognosis. But I believe now at least 15% of the people of small lung cancer can live up to about 5 years. What do you say?
Sir, you are very right, sir, and I am very happy, sir. You're so learned, sir. And sir, but sir, one message I would like to give: most of our colleagues, my senior colleagues, have been similar to the people who were physicians in 1950s, and they would always have a cigar or a cigarette, and they'll be very proud of that butt. So most of the smoking-related tumors are highly mutated and they are less likely to be responsive to chemotherapy, sir. Whereas if the lung cancers which are not smoking related, they are reasonably much better. So there are EGFR driven or ALK driven tumors which happen in non-smokers. They have really much better prognosis compared to the smoking related to the cancers, number one. Number two, even in this subgroup, now immunotherapy has been almost able to benefit 25 to 30% of these patients with fantastic results, sir. So, but having said that, yes, many of these patients do dismal compared to the other peers who are non-smokers or who cannot benefit from immunotherapy.
Wonderful, sir. Much learning. Thank you.
Sir, can I now
Sure, sir, sure.
take over from Dr. Tulsi's wholesale business to retail? My question, sir.
What was that?
So you mentioned about a book, Emperor of I couldn't get the next.
Sir, it's the Emperor of all melodies.
All the melodies. So I am reminded of the novel named The Final Diagnosis. Have you come across? Have you come across such a situation in your life?
Sir, so we come across this situation every day, sir. I don't know, I have not read that novel, but you could just imagine which situations are that I could actually...
So it's a dilemma changing from malignant to benign, benign to malignant. So,
okay, sir.
Yeah.
Okay.
So someone had a diagnosis made for the beloved that it's a sarcoma and amputation has to be done. And it was reviewed, it was said, no, it was not sarcoma. So, and then it was reviewed and it was said it was sarcoma. And then it was reviewed, it was said not sarcoma. So such something like...
Can I come in here? Can I come in here, Dr. Kalra? Regarding
you are the wholesaler, sir.
No, regarding the final diagnosis, Dr. Purohit. So there was a histopathologist, and there was a board on the wall of the hospital near the lab, which it was written no smoking. He would often go there, right under the board, he would light his cigar or his cigarette and smoke. And he had lung cancer. Thank you.
सर ऐसे तो बहुत लोग हुए हैं जिन्होंने कहा था कि कोई कोविड नहीं होता है एंड दे डाइड ऑफ कोविड. It was they were member of parliament. Anyway, sir, my question starts now.
Okay, sir. So, if I could pitch it. So, sir, very very relevant question, sir. The only thing which has happened, chabi chhod do, chabi room pe chabi. Sorry, sir. I'm so sorry. So, what has happened now, sir? What the good thing which has happened for us is that now we have newer tools which can help us differentiate between malignant and benign tumors. So we have very specific immunohistochemistry which have come now, sir. So this dilemma, I think the book was, if I'm not mistaken, it was
50 years back at least. At least 50 years back. Yeah.
Okay, sir. So then it was lymphoma was lymphosarcoma, sir. And we didn't have, we were still evolving with the classification of lymphoma. The main discussion used to be how to classify lymphoma. So from there, we are now moved to very specific diagnosis. Now moved also from diagnosis to not treating all lymphomas similarly, sir. So even a diffuse large B-cell lymphoma, if the varieties are different, there are triple hit, there are double hit, there are activated B cells, there is germinal B center. So, and each tumor type, in fact, for lung cancer, now we don't have lung cancer small cell and non-small. We have ALK driven, EGFR driven. So, the good thing is the final diagnosis is now becoming better for us, sir. But having said that, sarcoma is the one area, it can be really problematic. Some of the sarcomas are so low grade. Different deficiency from leiomyoma to leiomyosarcoma, sir.
Sir, we can say the earlier, the final diagnosis they were semi-final diagnosis.
Yes,
now
sir,
we
yes,
have
sir.
final diagnosis. So
We have more final diagnosis, but in our practice, still 1 in 100, we will have a problem, sir.
before I start my question, one comment about the CD4. If CD4 is less than 200, so do we have some policy like we increase the platelet count by infusing platelets? Do we have something to do for CD4 to make the patient accept the treatment? So please don't count them in my retail questions. My retail questions will start now.
Sir, I'm honored. So CD4 says that it has to improve if HAART has been instituted. So the purpose of HAART is to make the person rapidly become symptom free and also make their CD4 count beyond 400. That is the aim.
And yet we don't have any separators for CD4s.
No, sir.
So, my first question as a retail, we used to have in 30 years back also, use some immunotherapy, autoimmunotherapy for sinus and all that. Blood sample was sent somewhere abroad and some vaccine or injection were made. So, how does it differ from that immunotherapy to the immunotherapy which we are using for the cancer?
So, sir, all that was non-specific immunotherapy, and BCG has been one immunotherapy. So, BCG, I would say, the very famous saying, sir, whatever does not kill you makes you strong. So, that was BCG. So, BCG was the attenuated bacteria, it would be given to people, and that will actually increase their immunity. So, tried across many tumor types, worked for bladder cancer also, sir. Sometimes also worked against RCC and also worked in some patients of lung cancer. And apart from there were some trials with the dendritic cell vaccines and sometimes with self blood transfusion or antibody transfusion. All those were being done. But in the real world, their impact on the tumors were minimal. However, BCG has been successful for, I would say, mucosa-limited bladder cancers, and it has been routinely used for such patients. Apart from there, the previous immunotherapies are not being commonly used in our clinical practice today. But now right now immunotherapies are target driven. They are against specific tumor antidotes like PD-L1, which is programmed death ligand 1, or TIM3, or ERVD, or there are other markers which are being addressed through specific antibodies, and they are only expressed on tumor. They are tumor antigens. So anti-tumor antigens are being hit with these antibodies, and they're specific antibodies. So they're different from the non-specific, or I would say such therapy which would have an increase in the overall immunity, but not a tumor-specific antibodies.
So as per my experience goes, Herceptin was the first trastuzumab monoclonal antibody for the cancers. So how many have they evolved after that? Is it still evolving, or we are?
Yes, sir. Yes, sir. So as of now, in my clinical practice, I have 25 monoclonal antibodies of different types being used across more than 70 tumor types.
So HPV. So you very rightly said that in Western countries, they have taken the best advantage of HPV. In India at least, it is very restricted. And I find majority of my even very learned friends, they are not advising to their young female at least. Why not female? It should be even given to after sensing, even to the adolescent. And there is a dilemma. There is a lack of understanding. People are giving up to 40 years, maybe even 50 years. So I think 26 years is the best cutoff for the better advice for HPV. And HPV also has advanced from Gardasil 1 to Gardasil 9, I think. And they are all not available here. So this has a great scope for at least cervical cancer. What do you say?
So, sir, with respect to HPV vaccination, so HPV will naturally start happening to almost all of us once we start our sexual activities. So normally most women will start being sexually active by 21, and within 5 to 7 years they will start having a natural infection with HPV. So unvaccinated population, almost 90-95% is HPV infected. Now with respect to certain strains which are more cancerogenic compared to other benign strains. So there are certain strains which will cause only benign venereal warts to very malignant things which are like 6, 18, 31, 33. So these are common strains. So they are carcinogenic strains. And now we are looking there are 9 strains which are almost 90% of carcinogenic strains are among these 9 strains. So this is one thing. Now we have Gardasil 9 which is available in many countries. We have Gardasil 4. The recommendation is from 9 years to 25 years. Beyond 25 years, because the HPV could have been infection, the infection could have been there. So if somebody who has been never sexually active, even if at their 30 they can get vaccinated. But one more issue is that the higher the age, the lesser chances of having a long-term anti-HPV effect. The antibodies which are formed are short-lasting. So the younger the person is vaccinated, the more likely they have to have a strong B cells, which are memory B cells, and which can actually respond to a later infection also. Once we grow old, our immune response also dampens. So that is why recommendation is from 9 to 25, especially in women, but also in men. But yes, beyond 25, the chances of one is HPV being there is already high, and also the response to HPV vaccination might also not be very optimal. But if somebody wants to go for vaccination, there is no major harm. But recommendations don't say that we will go for vaccination.
Sir, I can feel the palpitation in Dr. Chauhan and other friends. They may be eager to ask question. My last question is, I have heard about magic fruit coming from South India to North India as an anti-cancer therapy. So some of my patients have referred to me the links, the YouTube and all that. Any experience of yours?
So these are all fancy fruits, sir. Like we had Baba Ramdev's Coronel. So yes, magic works in real life. People are happy. So it's for the people who are happy. It definitely adds some value. If fruit is fine, as far as people are happy to make them as a part of their treatment, I would say yes. Having said that, there are certain foods like curcumin, like ginger, and there are certain other foods which could have some anti-tumor or antioxidant treatment effects, which could actually make the tumor treatment much more effective, or side effects could be reduced with these drugs or these antioxidant properties. So if you say that is there any magical fruit which can prevent the cancer or can cure the cancer? No. But sir, then again, there are drugs like vaccines which are paclitaxel are being driven by plants. So in near future we might have certain more drugs being discovered from either plants or animals.
Sir, please don't count it as a question. जैसे आपने कहा था ना घर का बेटी लंका ढाए, तो क्या हम उन भेदियों में से उनका घर का बेटी निकाल सकते हैं क्या जयचंद उनके अंदर से एंड ट्रीट द कैंसर?
सर किनके अंदर से सर किनके अंदर से?
वो जो भेदी हैं उनके भेदी किसानों में से जैसे डोंट गो इनटू संयुक्त किसान मोर्चा उनके भेदियों में से भेदी निकाल के कुछ ले आए एनीवे सर.
I don't know, sir. I think somebody else might be able to answer it better, sir.
To make it lighter.
Hello,
yes.
Sir. Any role of booster dose for HPV vaccination?
So, ma'am, actually, till now we don't have any recommendations for booster vaccination. But then, having said that, if you are from 15 to 25, vaccination actually is 3 doses. So you have to give for. So actually, the third dose acts as a vaccination only. But yes, if you're younger, only 2 doses suffice. So probably in the older population, it will be better to go for 3 doses, with the third dose acts as a booster.
Okay, sir. Thank you.
Okay, ma'am. Okay.
Yeah, Dr. Sajjan, Dr. Podar.
Yes, sir. Yes, sir.
Doctor,
what is the role of
Dr. Podar, sir, can I?
हाँ बोलिए डॉक्टर चौहान. डॉक्टर चौहान कुछ बोल रहे थे?
Dr. Pradhan, can I ask a question? Before you ask a question, sir, can you preserve your question? You ask a question, sir, can you preserve your question? This is something which is important for me.
Yes, yes.
Go ahead, Sushil.
आपकी आवाज नहीं आ रही है. So, I think God wants कि मैं ही पूछूं पहले.
Sushil, गायब हो गया.
Sir, am I audible?
Now, yes.
Okay, Dr. Sajjan, thank you very much for a wonderful webinar on recent advances in oncology. My question is regarding one of my uncles. After a lot of effort, we have been able to diagnose him with marginal cell lymphoma. He was biopsied in Lady Harding, and we went to a pathologist in town, and ultimately we had to send a slide to Dr. Anita Borges in Mumbai from Tata Memorial, and she diagnosed him as a case of marginal cell lymphoma. And we went to Dr. Dharma Chaudhary, and Dr. Dharma Chaudhary said that we have to do nothing for him, and the lymph nodes which had appeared in the neck actually disappeared almost in the day when the diagnosis was made. He incidentally had movement which was seen by the ANT persons in Lady Harding, and they said that it needs to be an advanced case of malignancy, as there are lymph nodes in the neck, and there is a tonsillar enlargement. He also incidentally had hoarseness. Now, when he was further investigated, his PET scan showed some positivity in chest and at some places in bone marrow, but the report turned out to be marginal cell lymphoma. I went to Dr. Dharma Chaudhary with my uncle, and he said nothing needs to be done. Those lymph nodes disappeared, but again some lymph nodes have appeared in the neck at a different place, and he gets cough. So for that cough, Dr. Dharma Chaudhary advised that you get his this thing, indirect laryngoscopy done. Laryngoscopy was done, but there was nothing on laryngoscopy in Lady Harding. His vocal cords were fine. I want to ask you, sir, in marginal cell lymphoma, what is the strategy that the patient? He is 80-year-old.
So I think Dr. Dharma is right, because sometimes these marginal zone lymphomas are very low grade. So if they're not troubling him much, we can just leave it alone. If he's getting very symptomatic, then we could just add rituximab as a single agent. Rituximab could be given. That can really help solve the problem. We could actually see them after every 3 to 6 months. We can get a serial PET scan done and see what is the pace of disease. So probably I think because of his age, he would have decided that it might just remain there and not trouble him much. So I think once he has seen, he should be able to tell you better, because if, most of the symptoms might not be related to marginal zone lymphoma. It might just be
what are your OPD timings, and when can I send him to you for your consultation?
So my OPD timings from 9 to 2 every day, sir. I am in BL Kapoor Hospital. So 9 to 2 you can send Monday to Saturday, sir.
All right. So I will send him to you, sir. Thank you very much for your update. Sir, at the age of 80 years, if the patient is not having any fever, not losing any weight, no loss of appetite, can we continue to observe him, watch him?
Yes, sir. Yes, sir. We can observe.
We can. Right, sir.
Yes.
Sir, my second question is regarding not recent advances, but actually you would agree that the bottom line in malignancy still remains early diagnosis. And whatever malignancy you talk about, whether you talk about recent advances or most recent advances, or what is taking place in MD Anderson, you would agree, and everyone would agree, that it is the entire game is about early diagnosis of malignancy. So what is the advance in early diagnosing malignancies in our country? What is the strategy? You being one of the opinion leaders, what is your message to our physician colleagues?
So, sir, I think early diagnosis physicians have a huge role to play. So many times the patient will actually be coming to you with certain symptoms which the American Cancer Society has labeled as caution. So caution is the acronym for cough, which is more than 3 weeks, any change in the mole, and then urinary symptoms, then throat irritations or changes in the voice, and any abnormal breathing, nagging cough. So all this has been labeled as caution in the mnemonic. So anything which is troubling anybody for more than 2 to 3 weeks, and we should always investigate them. So that many times we are able to diagnose such things in an early stage. So that is early diagnosis. So apart from early diagnosis, we have screening programs now. Like for example, we have pap smears for cervical cancer. We have mammograms for breast cancer. We also have low-dose CT scans for lung cancer. We now also have bladder tumor antigen, which is a kit test for urinary bladder cancers as screening tools. And we have also risk of ovarian cancer algorithm programs for ovarian cancer. So many screening programs are ongoing for these, and I think we'll have one more meeting when we discuss these topics in detail. But such things can be employed to diagnose people early and make them cancer-free with early treatment, sir.
Sir, you mentioned something about immunotherapy, and I would like to mention 2 malignancies for the context. One is CA breast and another is CA lung. Sir, which of these 2 malignancies we are able to address better with immunotherapy, CA breast or CA lung?
So CA breast definitely any day, because CA breast has now become much more treatable and curable. But yes, in lung cancer now we have more role of evolving role of immunotherapy. The drugs are slightly different in both the malignancies, but both the malignancies, immunotherapy is being used. However, it is much more effective in breast as now compared to lung cancer.
Sir, even in stage 4 cancers with immunotherapy with CA breast, what kind of survival are we looking at?
So there are patients who are HER2 positive, which would otherwise not survive 6 months, are now able to survive 6 to 7 years with immunotherapy, sir. So there are many patients who are surviving much better with immunotherapy.
Sir, it would be pertinent to ask you, what would be the cost of such immunotherapy, sir?
So many of these immunotherapies are now generically available, which cost less than 1 lakh rupees. However, all the immunotherapy with drugs which are coming from outside India cost from 1 to 6 lakh rupees.
So we can put a high figure at 6 lakh rupees?
To as low as 12,000 rupees for Indian immunotherapies. 12,000 rupees to 6 lakh rupees.
Do we have some Indian companies coming out with the immunotherapy regime? Or we
Yes, sir.
What is very important?
No, sir. We have Reliance, we have Dr. Reddy's, Intas, lot of almost 10 Indian companies which are making this immunotherapy, sir, in India.
Sir, my last question, is there a role for immunotherapy in blood cancers like CLL?
Yes, sir. Immunotherapy is being routinely used in CLL also.
And what is the outcome? What is the result, sir?
So results are very fantastic in CLL. CLL has now almost become like median survival is more than 10 years now, sir, for CLL patients.
Great talk, Dr. Purohit. I must appreciate it. Is one of the best, as Dr. Tulsi said, on oncology, and I thank you from the bottom of my heart for being on Physicians Forum of India. Over to Dr. Podar, sir, for holding his question. Sir, go ahead, sir.
Dr. Sajjan, what is the role of immunotherapy in triple negative breast cancer? Where, for just benefit of all doctors, triple negative means HER2 and both ER/PR also negative. Yes.
Yes, sir. So there's a very emerging role of immunotherapy in triple negative breast cancer. So many of these will have one marker known as PD-L1. If that is being overexpressed, then we have 3 approved immunotherapy drugs in triple negative breast cancer, and which is being used in routine practice now.
Hey, but is it approved by FDA or any other organization like that?
Yes, sir. FDA approved. FDA approved immunotherapy drugs we have right now. One of the drugs is Keytruda. The other one was accelerated approved, which was known as Tecentriq, has now been stopped for some time. And we have one more drug which is in pipeline, which is again a PD-L1 inhibitor, nivolumab. So we have 3 drugs which have been used in triple negative breast cancer.
And can it be given with chemotherapy? Suppose is tumor is around 3 centimeters, no metastasis. So can you start immunotherapy with chemotherapy before surgery?
Hello. Sir. Okay. So Sir, can you hear me?
Yes, now. Now we can hear.
Okay. So, so chemotherapy is being used along with immunotherapy in many of these patients.
Okay. In adjuvant chemotherapy before surgery, we can use immuno with chemo, and then we can operate after that.
Yes, sir. So, there are many settings where they're using immunotherapy with chemotherapy, and once the tumor is not very nice, then we go for the surgery of such tumors.
Right. Okay. Thank you. Thank you.
I think we have to conclude this webinar after complimenting Dr. Sajjan for what a wonderful talk he has given, and we appreciate every word of yours. And I think since you are in the car and driving, I believe, so please drive safely, go home. And thank you very much for all the talks you given to us. Thank you so much, Dr. Sajjan.